Welcome to the Hospital Medicine Unplugged. We are undertaking a crucial deep dive today into really one of the most resource-intensive and high-stakes areas in the hospital. That's the evidence-based management of hemodialysis in hospitalized patients.
Yes, this is such a critical topic because, unlike managing chronic outpatient dialysis, dealing with these patients in the acute setting, it involves constantly shifting clinical parameters. We're focusing today on both acute kidney injury, AKI, and end-stage renal disease, ESRD. And our mission, really, is to distill down those critical clinical decisions. Things like timing initiation, picking the right modality, how to customize the prescription, and maybe most importantly, how to manage the complications for these patients who are often critically ill.
Okay, so let's start with a foundational definition, just to set the stage for what we're talking about achieving with this therapy.
Sure. Hemodialysis is an extracorporeal renal replacement therapy. Basically, think of it as an external kidney. It works using the principles of diffusion and ultrafiltration across a semi-permeable membrane. We use a specific fluid called dialysate. And the primary goal is really fourfold. Remove those accumulated metabolic waste like urea, pull off excess fluid, that's the ultrafiltration part, and correct severe acid-base and electrolyte imbalances that the patient's own failing kidneys just can't handle anymore.
And the real challenge in the hospital setting, as you mentioned, is we're not dealing with stable chronic patients here. We're managing dynamic instability.
Precisely. Hospitalization itself, whether it's from sepsis or acute heart failure, maybe a GI bleed, it means the patient's physiology is often rapidly changing, sometimes deteriorating. Their volume status can swing wildly back and forth. Comorbidities get exacerbated. And the acute illness itself is, well, it's a moving target, so the approach has to be incredibly nuanced and individualized. Often it requires almost minute-by-minute adjustments to the therapy just to keep things safe and effective.
Okay, let's move to that first big decision point, initiation. Especially in AKI, this is really a high-stakes moment. Our sources consistently point to the urgent need for dialysis when those life-threatening complications pop up, usually summarized by that classic AEIOU framework.
That AEIOU mnemonic it's really the lifeline here. It helps ensure we start renal replacement therapy based on genuine clinical urgency and, importantly, refractoriness to conservative management, not just based on some arbitrary lab value. If a patient is stable and we can manage their labs conservatively, maybe with meds or fluids, we should definitely maintain a watchful waiting approach. But AEIU means things are unstable and intervention is needed now.
Right. Let's unpack that mnemonic, starting with A for acidosis. And we're not talking about mild acidemia here, are we?
No, definitely not. We're looking for severe refractory metabolic acidosis. Generally, the literature defines this as a blood pH of, say, 7.20 or less, or maybe a bicarbonate level of 12 millimoles per liter or less. But, the number isn't the whole story. It has to be unresponsive to medical attempts to fix it, like giving aggressive bicarbonate infusions. And critically, acidosis at that level, especially pH below 7.20, it causes myocardial depression, peripheral vasodilation. It can make the patient completely refractory to vasopressor support. Leads to profound shock.
So that's why it's urgent.
That's exactly why we dialyze urgent.
Okay, EASE covers electrolyte abnormalities, and this focuses almost entirely on severe hyperkalemia, right?
That's right. The big one is severe persistent hyperkalemia. Typically, we're talking a serum potassium of 6.0 millimoles per liter or higher, especially if there are concerning signs on the ECG, peak T waves or widening of the QRS complex. And crucially, the patient must be unresponsive to the standard rapid-acting medical treatments. That means calcium for cardioprotection, insulin, and glucose to shift potassium to the cells. If those measures fail to bring the potassium down quickly, the risk of a fatal arrhythmia like VTAC or even a systole is just too high. You need urgent removal via dialysis.
Then I potentially fast-level compensation on you. For the hospitalist listening, knowing which specific toxins are dialyzable is absolutely key for making that potentially life-saving call to nephrology.
Yeah, this comes down to basic pharmacology. Dialysis works well for specific substances. They need to have a low molecular weight, low protein binding, and high water solubility. The classic list you need to know includes lithium, ethylene glycol, methanol, and salicylates. These get cleared really well by the dialyzer membrane. Knowing this list is paramount because if you wait for the other AEIOU criteria to develop from one of these specific toxins, the patient might have already suffered irreversible organ damage. You have to act sooner.
Makes sense. OWA is for overload, specifically refractory volume overload.
Right, and this really signifies a failure of medical management to protect the patient's oxygenation. The classic picture is refractory pulmonary edema causing severe hypoxemia. We often define this severity using a puff-iota ratio of 200 or less. If aggressive diuretic therapy hasn't worked and a patient needs escalating respiratory support, you absolutely have to remove that fluid with ultrafiltration. It's about protecting the airway, preventing the need for mechanical ventilation. So dialysis becomes a fluid management tool here, not just for waste clearance.
And finally, U for uremia. This signals that the kidney failure has progressed to causing systemic toxicity.
Exactly. Uremia means those accumulated waste products are now having direct end-organ effects. The key indications we look for are things like uremic encephalopathy, that's altered mental status. Could be anything from confusion to coma. Uremic pericarditis is another one. Or significant uremic bleeding, often from platelet dysfunction. These are clear signs that the uremic environment is actively harming the patient, and rapid waste removal is needed to try and reverse that damage.
Okay, so that AEIOU framework really clarifies the urgent initiation criteria. But what about the timing for most AKI patients, the ones who don't meet those immediate life-threatening criteria? We've seen some major shifts in the literature recently regarding early versus delayed initiation.
Yeah, this is probably one of the most significant updates in how we manage AKI over the last, say, decade. Consensus guidelines now really strongly support a watchful waiting approach if you don't have those urgent life-threatening complications we just talked about. The evidence, coming from multiple large randomized controlled trials, clearly indicates that early initiation of dialysis, meaning starting therapy proactively just based on rising creatinine or BUN levels alone, it doesn't actually improve overall patient mortality.
And in fact, there might even be a downside, a risk to intervening too soon.
Absolutely. Early initiation carries real, tangible risks without providing a clear benefit in many cases. You're immediately exposing the patient to the risks of catheter placement, infection, central venous stenosis. And you increase the chances of problems during dialysis itself, like intradialytic hypotension and that myocardial stunning issue. Plus, you have to remember, a pretty substantial percentage of AKI patients will actually recover their kidney function spontaneously within a few days. If we jump in and start dialysis early, we might be unnecessarily committing someone to a major invasive procedure when they could have potentially recovered with just conservative management.
So the threshold for non-urgent initiation is actually quite high then. We wait until complications develop or until the AKI is severely prolonged and not getting better.
That's correct. Non-urgent initiation is typically only warranted for persistent, severe AKI. That might be defined as prolonged anuria or oliguria, say, lasting more than 72 hours, or a really severely elevated BUN, often cited as greater than maybe 112 milligrams per deciliter. But importantly, only if conservative management, including really strict fluid control and metabolic adjustments, has definitively failed to stabilize the situation. Our clinical focus should really be on preventing AEIOU from developing while maintaining that watchful waiting stance for as long as it's safe.
Okay, so once the decision is made to initiate dialysis, the next step is selecting the modality. We've got intermittent, continuous, or these prolonged intermittent therapies. And since, as you noted, multiple trials haven't shown a significant mortality difference between them, how do we actually choose?
Yeah, that's a key point. Since survival outcomes seem similar across modalities if they're applied correctly, the decision is driven almost entirely by two things: the patient's hemodynamic stability and the logistical resources available at the institution. When we're choosing between IHD, CRT, or SLA, the main goal is to tailor the therapy to what the patient can tolerate in terms of fluid shifts and the speed of clearance needed.
Let's start with the most common one, perhaps. Intermittent hemodialysis, IHD. This seems to be the default for stable patients.
It is the standard, yeah. Typically done 3 to maybe 7 times per week, with sessions lasting about 3 to 6 hours each. It's ideal for patients who are hemodynamically stable, and it's often preferred when you need urgent, rapid clearance. Think about that severe hyperkalemia or certain acute dialyzable intoxications we mentioned. The major clinical drawback, though, and the reason we often move away from it in the ICU, is its association with the highest risk of hemodynamic instability. That rapid removal of large volumes of fluid and solutes over just a few hours, it really increases the risk of intradialytic hypotension and, critically, that myocardial stunning phenomenon.
Right, myocardial stunning. That's that temporary but repetitive ischemia and reperfusion injury to the heart muscle caused by the rapid drop in blood pressure and volume during the treatment itself.
Exactly. And that repetitive injury, it's a significant predictor of long-term cardiovascular problems and mortality. We really have to try and minimize that risk, especially in critically ill patients, which is why we often transition to continuous renal replacement therapy, CRT, for the really unstable patient.
So CRRT is kind of the gold standard if hemodynamic stability is the primary concern.
It is definitely the preferred modality for patients who are hemodynamically unstable or critically ill, especially those needing ongoing vasopressor support. CRT runs 24 hours a day, and it provides extremely slow, controlled fluid and solute removal. That superior hemodynamic stability is really the key advantage. It's also favored for patients who have acute brain injury or increased intracranial pressure, because that slow, continuous removal prevents the rapid shifts in plasma osmolality that could potentially worsen cerebral edema.
What are the main techniques within CRT? You hear terms like CVVH, CVVHD. What differentiates them?
Good question. CRRT is actually an umbrella term for several techniques. Continuous venovenous hemodialysis, or CVVHD, relies mostly on diffusion for clearing small solutes. You can think of it almost like slow, continuous IHD. Then there's continuous venovenous hemofiltration, CVVH. That uses convection, where a high rate of ultrafiltration literally drags fluid and solutes across the membrane. This tends to be a bit more effective for clearing middle-sized molecules. And finally, continuous venovenous hemodefiltration, or CVVHDF, combines both diffusion and convection. This maximizes the overall clearance speed, but it's also the most logistically complex to run. Regardless of which type you choose, the recommended dosing generally targets an effluent flow rate, that's the total fluid removed per hour, around 20 to 25 milliliters per kilogram per hour.
And the logistics of running CRRT 24/7 are pretty demanding, right? It requires specialized staff, continuous anticoagulation. Which brings us to the intermediate option, prolonged intermittent therapies, often called PR-AIR or SLED.
Exactly. SLN sustained low-efficiency dialysis is often seen as a great bridge between IHD and CRT. It delivers dialysis over a longer duration than standard IHD, typically somewhere between 6 and 12 hours. By slowing down the speed compared to IHD, it generally offers better hemodynamic tolerance. Patients handle the fluid shifts better. And crucially, it's significantly less resource-intensive than running CRT for 24 hours straight. You don't necessarily need the same level of staffing or continuous anticoagulation in all cases. A lot of observational data strongly suggests that outcomes with SLED are quite comparable to CRT in many ICU settings. So it's an excellent intermediate choice, especially when resources for full CRT might be strained.
And lastly, what about peritoneal dialysis, PD? It might feel a bit like a throwback for acute inpatient care, but it does have some important niche indications.
It does. PD is definitely a slower, gentler method. It uses the patient's own peritoneal membrane as the dialyzer. It is effective for managing things like acidosis and hyperkalemia, although it achieves correction much more slowly than the extracorporeal therapies like IHD or CRRT. Its main utility in the acute inpatient setting is really when there are absolute contraindications to using extracorporeal therapies. For instance, if a patient has a severe, uncorrectable bleeding risk that prohibits systemic anticoagulation needed for IHD or CRRT, or maybe severe peripheral vascular disease that makes getting reliable vascular access impossible. It also completely avoids the risks associated with central venous catheters. The main acute complication to watch for with PD, though, remains peritonitis.
Okay, let's shift our focus now to prescription customization. This seems like an area where the hospitalist and the nephrology team need to collaborate really closely. Why is just using a standard, maybe outpatient-style prescription potentially dangerous for an acutely ill hospitalized patient?
Because the acute patient's needs are fluctuating so dramatically, sometimes hour by hour. You just can't apply a standard outpatient prescription and expect it to work safely or effectively. The prescription absolutely has to be highly individualized. We need to carefully consider the duration of the session, the rate of ultrafiltration, and the composition of the dialysate fluid itself, all tailored to minimize complications. Think about it, a highly catabolic septic patient in the ICU requires a completely different dialysis approach than, say, a patient admitted primarily for pure volume overload who is otherwise relatively stable.
Let's talk about duration and frequency first. Is the general principle that longer sessions are often safer, hemodynamically speaking?
That's generally the consensus, yes. For patients who have very little or no residual kidney function left, the minimum recommended session duration is usually around 3 hours. However, for those really critically ill or highly catabolic patients, like the septic patient we mentioned, we often need longer sessions, maybe 3.5 to 4 hours, or even more. Or, alternatively, we might need to increase the frequency, sometimes doing dialysis daily, just to manage the overwhelming metabolic load and achieve adequate control of solutes and volume without causing that dangerous hemodynamic instability.
Now let's get to what seems like potentially the most dangerous element of the prescription, the ultrafiltration rate, or UFR. You mentioned a clear evidence-based threshold here we need to be aware of.
Yes, there's a very clear threshold, and it's backed by solid cardiac imaging studies. High ultrafiltration rates, specifically defined as pulling off fluid faster than 13 milliliters per kilogram per hour, are strongly associated with an increased risk of myocardial stunning and ultimately increased mortality.
13 ml per kilogram per hour.
13 ml per kilogram per hour. That's the number to remember. The physiological reason is that removing fluid that quickly actually outstrips the body's ability to refill the vascular space from the interstitial tissues. This leads to a sudden drop in cardiac output and critically impacts microcirculatory perfusion, which directly injures the heart muscle. So we must be really aggressive about avoiding rates above that 13 ml per kilogram hour threshold whenever possible.
Okay, so beyond just pulling off fluid, customizing the dialysate composition itself is crucial for metabolic safety too.
Absolutely critical. We have to tailor the concentrations of key electrolytes like potassium, sodium, and also bicarbonate in the dialysate fluid to match the patient's specific metabolic state. For instance, imagine a patient who comes in with a persistently high pre-dialysis potassium level, but who is also hemodynamically unstable. We might actually choose to raise the dialysate potassium concentration slightly, maybe to 3 or 3.5 milliequivalents per liter.
To prevent too rapid a drop.
Exactly.
Yeah.
To prevent a precipitous drop during dialysis that could itself induce an arrhythmia. It's also really important to avoid using the older acetate-buffered dialysate solutions. We should preferentially use bicarbonate-buffered solutions, which are physiologically better tolerated.
You mentioned a couple of mitigation strategies specifically for instability during dialysis, like dialysate cooling and sodium profiling. Can you briefly explain how those work for our listeners?
Sure. Dialysate cooling is actually a pretty simple but effective technique. We just lower the temperature of the dialysate fluid slightly, maybe by 0.5 degree to 1 degree Celsius, below the patient's core body temperature. This mild cooling induces a bit of peripheral vasoconstriction. That helps maintain systemic vascular resistance and therefore helps support blood pressure, mitigating that tendency towards intradialytic hypotension. Sodium profiling is a bit more complex. It involves varying the sodium concentration in the dialysate during the session. Typically, you might start with a higher sodium concentration and then gradually decrease it towards the end of the treatment. The idea is to prevent the rapid reduction in plasma osmolality that can drive fluid shifts into cells and contribute to hypotension. However, the evidence supporting routine use of sodium profiling is generally considered less robust compared to dialysate cooling.
And just quickly, regarding the hardware itself, the dialyzer membrane, does the type of membrane matter?
It does, yes. High-flux synthetic membranes are definitely preferred, especially when treating AKI patients. They tend to be more biocompatible, meaning less inflammatory reaction, and they offer better clearance of those middle-sized molecules. We should actively avoid using the older, unsubstituted cellulose membranes. They're known to be associated with a greater inflammatory response and are generally less efficient.
Okay, let's turn to vascular access. This is always a major consideration. For urgent dialysis, the necessary evil often seems to be the central venous catheter, the CVC.
Yeah, CVCs are pretty much indispensable when you need urgent, immediate dialysis initiation. They provide that immediate high-flow access we need. However, as you said, they come with the highest risk profile by far. Significant risks of infection, especially catheter-related bloodstream infections or CLAB-SIs, and also the long-term complication of central venous stenosis. And ultimately, CVC use is associated with increased long-term mortality compared to permanent accesses. So if a CVC is required, it should really be considered temporary. And whenever feasible, the right internal jugular vein is generally the preferred insertion site, always using point-of-care ultrasound guidance to minimize the risk of mechanical complications like pneumothorax or arterial puncture.
Now, for patients who need long-term dialysis, the traditional goal has always been a permanent access, ideally an arteriovenous fistula or AVF. But you mentioned the fistula first mantra has shifted somewhat.
It really has shifted quite dramatically in recent years. AVFs are still preferred for long-term use because they generally have the lowest rates of infection and thrombosis, and they tend to last the longest. But the big drawback is they require significant time to mature, usually about 2 to 4 months, before they can be reliably used. So now we employ a much more selective approach. We incorporate the patient's overall prognosis, their comorbidities, their life expectancy, and their personal end-stage kidney disease life plan into the decision. For example, think about a very frail, elderly patient with multiple significant comorbidities and maybe a life expectancy measured only in months. Does it make sense to put them through a complex AVF creation surgery, knowing it might never mature properly or they might not live long enough to benefit from it?
Probably not.
Probably not. In such cases, a less invasive option like an arteriovenous graft, or maybe even just managing with a long-term tunneled CVC. Perhaps focusing more on palliative symptom relief is often the more appropriate and patient-centered choice. It's not fistula first at all costs anymore. It's the right access for the right patient at the right time.
And this idea of preemptive planning means getting the nephrology team involved early, even before dialysis is actually needed.
Absolutely. Early referral for access evaluation is generally recommended when a patient's estimated GFR starts to decline consistently into that 15 to 20 milliliters per minute per 1.73 meters squared range. And a really critical aspect of this long-term planning is preserving the patient's peripheral veins. We need to be diligent about avoiding unnecessary venipuncture or placing peripheral IV lines in the arms, especially the non-dominant arm if possible. Every time you damage a vein, you might be eliminating a potential future site for definitive access. Vein preservation is key.
Okay, let's transition now to the monitoring and complication prevention strategies that are needed during the dialysis session itself. Once the prescription is set and the access is running, the real work of keeping the patient safe begins that continuous vigilance.
Vigilance is absolutely the operative word here. Continuous monitoring of vital signs, blood pressure, heart rate, oxygen saturation, that's standard practice for every treatment. Given that risk of myocardial stunning we discussed, frequent, ideally real-time, assessment of the intradialytic blood pressure is mandatory because intradialytic hypotension, or IDH, is far and away the most common acute complication we encounter.
When should we absolutely mandate continuous ECG monitoring during the session?
ECG monitoring becomes essential for patients we identify as being at particularly high risk. This definitely includes patients starting dialysis with severe electrolyte problems, like that critical hyperkalemia. Also, patients with recent or ongoing AKI, as their cardiac stability might be compromised. And very importantly, any patient receiving dialysis specifically for an intoxication with a known proarrhythmic agent. Remember, the electrolyte shifts during dialysis, especially rapid drops in potassium, can precipitate life-threatening arrhythmias, QTc prolongation, even sudden cardiac death. So continuous surveillance is necessary in these high-risk groups to catch those events immediately.
Fluid status assessment is so critical, but often relies on just comparing pre- and post-dialysis weights. Trying to hit that elusive dry weight safely is a huge challenge. How can some of the technical methods help guide us?
Yeah, optimizing hydration is arguably one of the most challenging parts of managing dialysis, especially inpatient. Both leaving residual fluid overload and pulling off too much fluid, causing depletion, are clearly linked to increased mortality. While clinical examination checking for edema, listening to the lungs, assessing JVP, and tracking those serial weights are absolutely foundational, technical methods can provide more objective guidance. Bioimpedance spectroscopy, or BIA, is one example. It can estimate total body water and, more specifically, extracellular water volume.
Giving you a target.
Exactly. It can help provide a more objective target for what that patient's ideal dry weight might actually be, moving beyond just subjective clinical guesswork. This allows us to calculate safer, potentially more precise ultrafiltration goals for each session, which should, in theory, minimize the risk of hitting that dangerous UFR threshold and causing hypotension. Blood volume monitoring during this session is another technology used in some centers for similar reasons.
Let's focus specifically on intradialytic hypotension, IDH again. You mentioned it occurs in a substantial number of treatments, maybe 4 to 17% of sessions. Why is it such a big deal?
IDH is a major problem because it's not just a transient dip in blood pressure that makes the patient feel unwell for a few minutes. It's strongly associated with increased cardiovascular morbidity and mortality downstream, mostly due to that resultant myocardial stunning and potentially watershed infarcts in other organs like the brain or gut. Prevention strategies really start with the prescription individualizing the ultrafiltration goal to be achievable within the session duration without exceeding that 13 ml kCHA rate is absolutely key. And then we employ those mitigation techniques we talked about earlier. Dialysate cooling is probably the most evidence-based, and occasionally sodium profiling might be considered to help stabilize blood pressure during the run.
And then there's one of the more feared, though thankfully rare, complications, dialysis disequilibrium syndrome, or DDS.
DDS is serious because it directly affects the central nervous system. It can manifest as headache, nausea, vomiting, muscle cramps, restlessness, and in severe cases, even seizures or altered mental status progressing to coma. It primarily occurs in patients who are just starting dialysis for the first time and who have extremely high blood urea nitrogen, or BUN, levels. The mechanism is thought to be the rapid removal of urea from the bloodstream by dialysis. This creates a temporary osmotic gradient because urea takes longer to diffuse out of the brain tissue than out of the blood.
So water shifts into the brain.
Exactly. Water shifts osmotically into the brain cells, potentially causing cerebral edema. The prevention strategy is actually quite straightforward but critical. When initiating dialysis in someone with a very high BUN, you use lower blood flow rates through the dialyzer, and you prescribe shorter, maybe less efficient initial sessions. The goal is to lower the BUN more gradually over the first few treatments, minimizing that rapid osmotic shift.
And of course, given the frequent reliance on CVCs, especially early on, infections remain an ever-present risk.
Absolutely. Catheter-related bloodstream infections, CLABSIs, are unfortunately extremely common in this population and carry significant morbidity and mortality. Preventing them requires strict, meticulous aseptic technique during every single connection and disconnection procedure. Hand hygiene, proper site care, scrubbing the hub, all of it is critical. If sepsis is suspected in any dialysis patient, especially one with a catheter, empiric antibiotics must be started immediately after drawing blood cultures. And the coverage needs to be broad initially, typically covering both gram-positive organisms like Staph aureus, which love plastic catheters, and gram-negative organisms reflecting potential hospital flora exposure.
Okay, let's pivot now to delineate the specific clinical role of the hospitalist in managing these patients. When a patient on your service develops AKI, or maybe an acute issue related to their ESRD, what are the hospitalist's core initial responsibilities?
The hospitalist is really the central coordinator and decision maker, especially at the outset. Their first responsibility is that comprehensive clinical assessment. First, are there any urgent AEIOU indications that mandate immediate nephrology consultation and likely dialysis initiation? Second, and this is crucial, the hospitalist must actively assess for and manage any reversible causes of kidney dysfunction before jumping to the conclusion that dialysis is inevitable. Things like volume depletion, ruling out urinary tract obstruction, treating sepsis, reviewing the medication list for nephrotoxins. Initiation of dialysis should never be based solely on a lab threshold, like a specific creatinine or GFR number. It has to be driven by the overall clinical picture and the failure of appropriate conservative management.
And the hospitalist also often leads the crucial conversations around shared decision-making, particularly in complex cases.
Yes, absolutely. Shared decision-making and advanced care planning are essential, especially when dealing with the frail or elderly population, or those with multiple serious comorbidities. The hospitalist is often best positioned to initiate these sensitive conversations about the patient's overall prognosis, their values, and their goals of care. For some patients, particularly those with severe frailty, advanced dementia, or end-stage multi-organ failure, pursuing aggressive, life-prolonging dialysis might not align with their goals or offer meaningful benefit. In these situations, discussing the option of palliative dialysis, focusing solely on managing symptoms like fluid overload or nausea to improve comfort, may be the most appropriate and ethical path forward.
And practically speaking, when should the nephrology team be formally brought into the discussion or consulted?
Early consultation is almost always beneficial. It's typically considered mandatory when the estimated GFR consistently drops below 30 milliliters per minute per 1.73 meters squared, even if urgent dialysis isn't needed yet. Or if the clinical picture suggests a high risk of progression to ESKD in the near future. Getting nephrology involved early allows for that crucial preemptive access planning we discussed, helps guide complex medication management, and ensures the dialysis prescription, if needed, is optimized from the start.
Let's talk more about medication adjustments and safety. You highlighted a really quite terrifying statistic from the sources. Up to 92% of hospitalized dialysis patients might receive at least one inappropriately dosed medication. This seems like a massive area for potential error.
It is a critical patient safety issue, absolutely massive. Drug dosing in these patients has to be meticulously individualized. It's not just about reduced renal clearance, although that's obviously a major factor. We also have to constantly consider the drug's stylizability. Is the drug going to be significantly removed by the dialysis treatment itself? A drug is more likely to be removed if it has certain properties, typically a low molecular weight, low protein binding, and high water solubility. If a drug is highly dialyzable, we run the risk of removing too much of it during the treatment, potentially leading to subtherapeutic levels and treatment failure.
Can you give us some concrete clinical examples of drugs where this is really important?
Sure, absolutely. Think about vancomycin, a very common antibiotic used in hospitals. It is dialyzable to a significant extent, We rely on trough levels to ensure it's working effectively. If we give a standard dose just before a dialysis session, a good portion of that dose might be removed during the treatment. Therefore, vancomycin frequently requires specific post-dialysis dosing, or sometimes intradialytic dosing, to maintain those necessary therapeutic trough levels. Other highly dialyzable agents that often require dose adjustments or post-dialysis supplementation include certain antiepileptics like gabapentin and topiramate. Many other antibiotics fall into this category too. Ignoring dialyzability can lead directly to therapeutic failure. Conversely, if a drug is not dialyzable and relies on kidney excretion, failing to adjust the dose appropriately for the lack of kidney function can lead to dangerous accumulation and toxicity.
What about pain management? Opioids seem like another area requiring careful selection.
Critically important. We must generally avoid morphine in patients with little to no renal function, especially those on dialysis. This is because its primary active metabolite, morphine 6-glucuronide or M6G, is cleared by the kidneys. If kidney function is poor, M6G accumulates and can cause prolonged and profound sedation, respiratory depression, and neurotoxicity like myoclonus. Therefore, opioids like hydromorphone and fentanyl are generally preferred in dialysis patients. Their metabolites are either inactive or much less active and are not as reliant on renal clearance, offering a significantly safer profile for the anuric or severely renally impaired patient.
And it sounds like the need for relentless avoidance of nephrotoxic agents has to continue, even in patients who already have established ESRD or severe AKI.
Yes, we still need to be hypervigilant. NSAIDs, the non-steroidal anti-inflammatory drugs, should generally remain contraindicated, as they can potentially worsen any residual kidney function in AKI patients or cause other issues like GI bleeding or sodium retention. And for patients needing contrast imaging, gadolinium-based contrast agents used in MRI must be avoided or used with extreme caution in patients with severely reduced GFR on dialysis, due to the significant risk of nephrogenic systemic fibrosis, a devastating systemic fibrosing condition. Given that shocking 92% error rate reported in some studies, it underscores that safe medication management in hospitalized dialysis patients absolutely requires close collaboration between the hospitalist, the nephrology team, and critically the clinical pharmacists. Every single medication needs careful review.
Let's touch on nutrition and electrolytes in the acute setting. Protein energy wasting, PEW, sounds highly prevalent in this group.
It is extremely common, and it significantly contributes to poor outcomes like increased infection risk, poor wound healing, and higher mortality. Remember, the acute illness itself, sepsis, surgery, trauma, is a highly catabolic state. On top of that, the dialysis procedure itself can sometimes lead to nutrient losses, so we must be really aggressive about supporting nutrition. The target protein intake is actually quite high, typically recommended at 1.0 to 1.2 grams per kilogram of ideal body weight per day. And that can even escalate up to 1.5 grams per kilogram per day during periods of severe acute illness, just to try and combat the intense inflammation and catabolism. Energy intake should generally aim for around 30 to 35 kilocalories per kilogram per day.
Wow. Balancing that high protein demand with the typical electrolyte restrictions must be incredibly complex for the dietitians and the team.
It is a constant tightrope walk, absolutely. Those dietary restrictions always have to be balanced against the overriding need to provide adequate nutrition, especially protein and calories. Sodium is usually restricted, typically to less than 2.3 grams per day, mainly to help control interdialytic weight gain and blood pressure. Phosphorus is also restricted, usually aiming for 0.8 to 1.2 grams per day, although achieving this with high protein needs can be very difficult and often requires phosphate binders. However, potassium restriction, often recommended as less than 3 grams per day, is typically only necessary if the patient's pre-dialysis potassium level is persistently high, say 6 milliequivalents per liter or greater. We don't want to unnecessarily over-restrict potassium, especially if the patient is already struggling to meet their caloric and protein needs from their diet. It's always individualized.
Okay, our final section focuses on escalation and prognostic factors, particularly thinking about the intensive care unit. When does a dialysis patient need to be escalated from the general ward to the ICU?
ICU admission becomes necessary whenever the patient's clinical condition exceeds the monitoring capabilities or treatment intensity that can be safely provided on the general medical floor. Key triggers for escalation include persistent hemodynamic instability, meaning ongoing hypotension that isn't responding to standard interventions like fluid boluses or adjustments to the dialysis prescription. Also, severe respiratory failure requiring mechanical ventilation, the development of new or worsening multi-organ failure, the need for continuous vasopressor infusions to maintain an adequate mean arterial pressure. And additionally, any life-threatening cardiac arrhythmias, or obviously a cardiac arrest occurring during a dialysis session, would mandate immediate escalation to the ICU for comprehensive critical care support.
When chronic dialysis patients do require ICU admission for an acute illness, what does the data generally tell us about their prognosis?
Unfortunately, the prognosis is often quite guarded. It reflects the significant burden of their underlying chronic kidney disease, combined with the severity of the acute critical illness that led to the ICU admission. Short-term mortality rates for chronic dialysis patients admitted to the ICU are typically reported as being extremely high. Some studies cite in-ICU mortality rates around 41%, or even higher depending on the reason for admission. This is a stark reality that we need to communicate clearly and compassionately with patients and their families, as it heavily informs discussions around goals of care. Are there specific indicators or prognostic factors that predict particularly poor outcomes that the hospitalist should be watching for closely in these ICU patients? Yes, there are several well-recognized factors. Poor outcomes are strongly associated with high non-renal SOFA scores, the sequential organ failure assessment score. This is a really crucial distinction. It's often not just the kidney failure itself that dictates immediate prognosis in the ICU, but rather the failure of other organ systems, particularly respiratory failure requiring mechanical ventilation or cardiovascular failure needing vasopressor support. Other poor prognostic markers include things like a low serum albumin level, which reflects that protein energy wasting and severe systemic inflammation we talked about, and also severe hyperphosphatemia, which might indicate inadequate dialysis clearance but also affects overall illness severity and potentially contributes to cardiovascular risk. Conversely, some studies suggest that interventions focused on careful, individualized ultrafiltration to avoid hypotension and minimizing the duration of CVC dependence are associated with improved survival chances.
This entire deep dive really underlines that successfully managing hemodialysis in the inpatient setting is truly a high-stakes balancing act. It feels like a continuous equilibrium problem you're trying to solve.
It really is a continuous equilibrium. We are constantly balancing the absolute need for effective waste removal and precise volume management against the very real, life-threatening risks posed by the therapy itself, namely that hemodynamic instability and the potential for myocardial injury. Success demands constant vigilance from the entire team, strict adherence to those individualized prescription parameters, especially avoiding that dangerous high rate of ultrafiltration, and requires constant proactive adjustment based on the patient's dynamic, ever-changing acute status.
Now, earlier we established that CRRT is often chosen for the most critically unstable patients, primarily because of its superior hemodynamic stability compared to standard IHD. However, we also repeatedly noted that multiple large clinical trials have failed to show a clear mortality benefit when comparing CRRT head-to-head against intermittent or prolonged intermittent therapies, assuming those are delivered optimally.
That is the enduring clinical paradox, isn't it? CRRT is by far the most resource-intensive modality. It's logistically complex, it's expensive, it often requires specialized nursing teams, and usually mandates continuous anticoagulation with all its associated risks. Yet despite its theoretical advantage in stability, it doesn't demonstrably improve survival over other modalities if those other modalities are applied thoughtfully and carefully.
Which raises, I think, a really fundamental clinical question, something perhaps for you, the listener, to explore on your own or discuss with your colleagues. If we become truly expert at rigorously optimizing intermittent therapies, maybe through more sophisticated techniques like precise feedback-controlled dialysate cooling, maybe careful sodium profiling tailored to the individual, and certainly by embracing the routine use of prolonged lower efficiency sessions like SLAD, can we reliably achieve the necessary hemodynamic stability that we currently associate mainly with CRRT, but do so without incurring that high resource cost and the burden of continuous anticoagulation? This ongoing optimization of intermittent techniques, making them as hemodynamically gentle as possible, remains a really critical area for ongoing clinical practice improvement and future research.
Thank you for joining us for this essential deep dive into the complexities of inpatient dialysis management.
Thank you.